Hi, everybody. Okay, so we have 1.5 hours today. So, yeah, thanks, Emily, for the introduction. So I'll just get started. So we have a lot to cover. So today I'll be talking about trauma-informed care. I think the title has somewhere in it trauma-specific care, so hopefully that was changed, but we'll talk about the difference later between trauma-informed care and trauma-specific care, but just to put up front at the beginning, this is about trauma-informed care. So there was a previous webinar that I did called Understanding Trauma. Hopefully that is also available to you. So that talk focused more on post-traumatic stress disorder and diagnosis and treatment of psychiatric disorders related to trauma. So here we'll be talking about trauma in a more general sense, how trauma can affect the work that you do. So I'm hoping this will be applicable not just to a medical audience, but just people who provide services of any kind to people who may have experienced trauma. So how we can prepare our organizations and the environments where we provide services to help safely engage people who may have experienced trauma. And I'll talk about how and when to ask about trauma if we need to ask about it, to share information about trauma, and also if there is like an acute reaction related to trauma that comes up in the course of our work, how do we deal with that? So when we talk about trauma, one of the things I'll bring up a few times in the talk is that you can think about trauma as overwhelming stress that overcomes somebody's ability to cope. So if you see the word trauma in the presentation, you can replace it with stress, and hopefully that will make the talk more broadly applicable. So we're not just talking about strategies that help deal with people who have experienced trauma, but hopefully the same principles can be applied to just general stress in the workplace or dealing with people who are stressed out. So from that, you can get some ideas about how work can be hopefully less stressful and more satisfying. So I'll be covering the impact of trauma, different forms of trauma, what risks that trauma poses to clients as well as service providers, general principles to support people who have experienced trauma, and then how those principles can be applied to preventative measures to avoid harm to people, and also the management piece, like if a trauma reaction comes up, what we can do about it. So I'll start with the impact of trauma. We'll talk about the scope of trauma, define trauma, talk about different forms of trauma and how the form of the trauma can influence what kind of effects it has on people. And I think this is probably the most important section of the webinar, because if we understand how trauma works and how it affects people, we can apply that understanding to prevention and management. So when we look at the scope of trauma, actually from Canadian statistics, more people than not have experienced some form of trauma in their lifetime. Most people do not have post-traumatic stress disorder, but if you look at trauma in general, it's actually very common. And this is, I'd say, a relatively peaceful, stable society we have in Canada. So if we're dealing with people who have come from elsewhere where maybe society is less stable, or there may be war or other kinds of violence going on, then these rates might be even higher. So as I said before, the previous webinar about understanding trauma covers in more detail the effects of trauma, the diagnosis of trauma, symptoms of trauma, PTSD. But I think it's important to at least recap it again here so we can use it to frame the rest of our discussion. So once again, we can define trauma very broadly speaking as stress that overwhelms a person's ability to cope with it. When we look at the diagnostic criteria that psychiatrists use, how we define trauma as it pertains to a diagnosis of post-traumatic stress disorder, the definition is much narrower. So we're looking at actual or threatened death, injury, or sexual violence. So it's a much more restrictive definition. So there's different ways of understanding or defining trauma, but I believe that if we look at trauma through a broader lens and seeing it as a continuum that ranges in severity, that makes our understanding of trauma more broadly applicable. So we can apply this knowledge to ourselves, to people who we serve who don't necessarily have a PTSD diagnosis, but may be experiencing some effects or consequences of trauma. So the form of trauma that people experience can influence what kind of effects it will have on them. So trauma can differ in terms of the intensity of the trauma, how frequent, how many times it happens, is it repeated or is it a single incident, and where did the trauma come from? Did it come from another person or did it come from a natural event or the environment? And all of these factors affect the meaning of trauma to the person and the effects that it will have. So just basically more intense trauma, more repeated, more prolonged trauma that's of a personal or interpersonal nature where it was another person who did it as opposed to what you could say is an act of God. That tends to have more wider impact and more harmful effects, and I'll get into more detail in a bit. So we can classify trauma somewhat arbitrarily into 5 categories. They're not mutually exclusive. They can overlap and be interrelated, but they help us to see the range of traumatic experiences that people can have. So the first category you could say is single incident trauma. So this is what we think about when we think about like a simple case of post-traumatic stress disorder, like a relatively otherwise healthy person goes through a single stressful event, like a car accident or being mugged or being attacked or assaulted, and that leads to the classic symptoms of PTSD that are defined in the DSM. So I'll cover that a little bit later. Simple trauma or single incident trauma is contrasted with complex trauma. So complex trauma is what we're referring to when it's trauma that is of an ongoing or repeated nature that takes place again and again over time, and often where escape from the situation is difficult or impossible. So this could be like family trauma, abuse or domestic violence that occurs over a period of time in a household, or it may occur in other situations like war, for example, where there's also ongoing repeated trauma and people often cannot leave or escape that situation easily. So this kind of trauma has more complex trauma effects, and we'll define those when we get to effects of trauma. Developmental trauma is complex trauma can be developmental in nature. The developmental part refers to the trauma occurring early in the course of a person's development. And this trauma is often complex because children are not able to escape or leave a situation. So this could include neglect, abandonment, chronic abuse, or witnessing violence in the home. And trauma like this that occurs at an early age tends to interfere with people's systems of attachment, so how they bond with other people, and that can have effects down the road in terms of how they relate to others. Historical trauma is trauma that happens to large populations, large groups of people, and this can often take place over an extended period of time and have effects that affect multiple generations. So these are massive events like genocide, war, slavery, colonization. So historical trauma often has intergenerational effects. So you can get intergenerational trauma from a historical traumatic event, but it could also happen with a smaller scale trauma. But basically what this refers to is psychological or emotional patterns that are passed from one generation to another that are the result of trauma. So this could be attitudes or adaptations or coping strategies that the traumatized generation adopted and then has passed on and offspring have learned from observation or direct teaching, but these may be not adaptive in a different context under different circumstances. You can also get intergenerational effects from the mechanism of just living with a person who is exhibiting effects of trauma. So for example, a parent with post-traumatic stress disorder who is emotionally unavailable, or they may be angry or abusive, and that has direct effects on the children as well. So they may become like caretakers to their parents, they may repress their own needs, they might act out and become defiant, or they may become eager to please and subservient. So different effects on development. So if we look at the different forms of trauma, we can see that there's quite a spectrum in terms of how often it happens, the complexity, and also how it can affect people through time and through different generations. So we can divide the effects of trauma into simple trauma effects and complex trauma effects. The simple effects are described in more detail in that Understanding Trauma webinar, but basically when you look at the diagnostic criteria of post-traumatic stress disorder, these are simple trauma effects. So you can categorize them into 3 or 4 categories. So hyperarousal, hypoarousal or avoidance, negative emotion, and intrusions. So the hyperarousal refers to like anger, irritability, sleep disturbance, trouble concentrating. So somebody becomes so physiologically aroused that they're not able to relax. And then you get people swinging to the opposite pole where they are emotionally numb, they avoid things, they disconnect or they disassociate from life. And so that's the symptom on the opposite pole. I got a question here, will the slides be mailed out? That's fine with me. I think the webinar is being recorded, so it should be made available for people later. So negative emotion, that refers to depression, guilt, shame. These kinds of emotions often result from trauma. And the intrusions, that's like flashbacks, intrusive memories, people thinking about the trauma when they don't want to think about it, or being reminded in a way that actually feels like they're experiencing the trauma again. And these intrusions can interfere a lot with everyday life as well. Complex trauma is So it's not part of the diagnostic criteria for PTSD, but these kinds of effects can be quite debilitating as well. And the complex trauma effects result from the complex trauma that we discussed earlier, trauma that's repeated and where escape is not possible. So complex trauma can have the effect of more severe PTSD symptoms. So the simple trauma symptoms can happen, but worse, or there can be more comorbidities, and we'll get to that on the next slide. People may also experience complex trauma and not have the classic or simple PTSD symptoms, but they can have other effects, which I've classified as effects on personality and factors that make people vulnerable to further trauma. So we'll get to that in a few slides. So people who have had complex trauma can have more comorbidities, depression, anxiety disorders, more emotional dysregulation, aggression, anger, self-harming behaviors, eating disorders, drug use. So with developmental trauma especially, you may not see the classical PTSD symptoms, but you do have these other comorbid issues. Complex trauma affects, in terms of effects on personality, that also can happen with developmental trauma when I refer to the effect on people's attachment style. Basically, if you think about simple trauma as something that happens to somebody who has an otherwise healthy personality, complex trauma, instead of getting PTSD symptoms overlaid on top of a healthy personality, you start to affect or undermine the underlying personality structure. So what I mean by that is people can experience changes in self-concept, changes in their worldview. So for example, becoming distrustful of other people, feeling shame about themselves, feeling worthless, feeling alienated from other people, feeling like there's something fundamentally different about them that other people can't relate to. So they can't have relationships, they can't have friendships. Complex trauma actually has been shown to affect brain functioning, so people's ability to self-regulate and emotionally regulate becomes impaired, so they're more vulnerable to outbursts of anger, dysregulated emotion, and also dysregulation in behavior. And that speaks to why they may become more vulnerable to further harm or trauma. Because if they are not able to regulate their emotions as well or their behavior, they'll be more prone to self-destructive activities like abusing drugs or self-harm. They can also fall into unhealthy relationship patterns because their ability to attach to other people in a healthy way is damaged. So they might sort of override their usual caution and just attach to whoever is available, and so they become involved with people who are not necessarily healthy for them. Or they don't attach to anyone and they become very isolated and alienated from other people, and that makes them vulnerable as well because they are not connected to the rest of society and they don't have the support that they otherwise would have. Or you can see both patterns in the same person. So that is some explanation, I think, about why for some people you see that there seems to be no end to the problems that they have, like they've been traumatized, but then bad things just keep on happening to them and it's like they can't catch a break. So the effects of developmental trauma, I think we've actually discussed already in terms of how people relate to other people, the effects on the ability to self-regulate and attachment styles. So we can just blow through that slide and move right on to risks of trauma. So now we've talked about how does trauma affect people, how does it affect their behavior, how does it affect how they relate to others. We've also talked about how trauma really is quite ubiquitous, that more people than not will experience some kind of traumatic event, and that event might not give them PTSD, but it will probably have some effects. So if we're in any kind of service industry where we are providing some kind of service or help to the general public, we are going to run into the effects of trauma sooner or later. And I think having that understanding of how trauma affects people will help us understand how is that trauma going to affect their experience of us and our experience of them. And that's where we see, I believe, the risks from trauma. So if we look at how trauma affects clients' relationships to us or their experience of us, I think the two main issues are that they can have re-traumatizing experiences, and their trauma symptoms can actually interfere with their ability to seek help and engage with services. So re-traumatization is what happens when a person's interactions with institutions or service providers actually causes further trauma to them. And how this tends to happen is when we're providing a service and we have some kind of power or authority over people, there's always the potential to apply that authority in a way that feels coercive and actually takes people's power or choice away. And that is actually one of the features of trauma, that people are not able to control what has happened to them in that traumatic moment. So anytime we may step in and control people, there's the potential that that could be experienced as traumatic. So the probably the most glaring example in my line of work is what happens in hospitals. Like if people are emotionally dysregulated and they're angry, they're behaving in an aggressive way. Especially in the past, what we would do is we would put them in restraints and inject them with tranquilizing medication. So you can imagine, like, if somebody has felt helpless in their life before because they've been traumatized, like just what that kind of experience is going to feel like. And I hear it from patients, like that kind of experience, even being kept in the hospital when you don't want to be there, not necessarily being restrained or medicated against your will, like that leaves an impression and people don't easily forget that. The other issue that people can have, clients who have experienced trauma, is their trauma symptoms can interfere with access. One way that it interferes could be actually in the moment or in the meeting, where they're experiencing a flashback or they're dissociating and they can't actually participate in the process. But beyond that, like their anxiety or being distrustful of authority or power, or just feeling anxious about meeting new people, like that all can be a barrier to them coming for help and getting services. So on the other hand, you can't forget the people who are providing the services, because they are also part of the interaction. So clients can be traumatized, but service providers can also experience vicarious trauma. And when people are difficult to deal with because of their traumatic experiences, like they don't relate well to other people, they're angry, they're anxious, they're mistrustful, the service providers are on the receiving end of that. So you're the ones who have to deal with these kinds of difficult encounters. So I see that as a risk that trauma creates. So the effects of working with trauma survivors has been termed vicarious trauma. There's also the concept of compassion fatigue in the healthcare field, and the idea of burnout. And I think these concepts all overlap and kind of talk about the same thing, but maybe from a different theoretical perspective. I think the effects of vicarious trauma and burnout look the same, and if you think about burnout as using up all of your reserves, whether that's physical, emotional, or mental, working with trauma is emotionally and mentally draining, so vicarious trauma causes burnout. So the emotional effects of burnout tend to be loss of interest or apathy, disengagement from the work, or anxiety, self-doubt. It can also manifest as anger or irritability. The behavioral effects may be fleeing the situation, just leaving the job, avoiding coming in late, showing up but not being productive, or on the other hand, people can actually overwork to try to recapture their sense of effectiveness that can be lost when you're just working with overwhelming trauma, like horrible situations that you're witnessing that you can't undo or change. And it can affect our relationships with our coworkers, so becoming withdrawn or irritable, impatient, not communicating effectively, getting into conflicts. So we can have trouble relating to each other. We also can encounter difficult relationships with clients that may have trauma as one underlying cause. So the people who are difficult, oppositional, provocative, people that try to question your credentials, undermine your authority, those people are often the ones who have experienced trauma. So I've just labeled that under the general heading of unpleasant encounters. The other potential issue that you can get into with, especially with trauma, is boundary problems. So under-involvement or over-involvement with clients. And whenever you get into a boundary issue, that's where you tend to deviate from your usual practice. And when you deviate from your usual practice, that's when you make mistakes and you get in trouble. Like you do something inappropriate, or you do something that you're not supposed to do. Like in my line of work, maybe that's like prescribing medication that you shouldn't otherwise prescribe because somebody asks for it. Or you give them appointments at a time of day that's like not really suitable and puts you at risk. For example, like seeing people in your office after hours when nobody else is there. I've put an example of just general unpleasantness on the slide here. But just, I think the main takeaway point is that somebody who behaves in an irritable or provocative or angry way, that's often a defense mechanism, and they're dealing with fear or vulnerability. So they may be acting angry at you because they're actually afraid of the situation, or they're afraid of you or the power that you have or what you might do. And the experience here is actually something that I remember experiencing like a few years ago. Somebody showed up late for their appointment, first consultation at the clinic. I was a little bit irritated about that, and it probably showed because I was behind schedule, and then just kind of taking me by surprise, like this person just launched into like just questioning my credentials and my age, and like I look too young to be a psychiatrist. And so right from the get-go, I was on the defensive. And looking back on that situation, I suspect, I can't be sure because I didn't see her again, that she was probably scared of me because I was irritated at her, and so she was going on the offensive, possibly unconsciously, just to ward off my being irritated with her. So when we look at under and over involvement or boundary issues, that often happens because our buttons have been pushed. So the experience of dealing with the person with trauma generates an emotional response in us, and that causes us to react. So one way that can manifest is over-involvement with people. So we may be reacting to a person who's demanding and we don't want to let them down, or somebody who's idealizing us, like they're looking for a rescuer, and we are playing into that. So that might look like failure to set limits or boundaries, offering more help than is necessary or appropriate or desired, or when we identify with the client's experience and we project our experiences onto them, and we actually fail to recognize how their experience actually doesn't match ours. So we may, for example, think that we have a great rapport with somebody because we've been through the same thing and we can understand them, but actually we haven't quite got it, and it actually bothers them, and they're getting irritated, but we don't pick up on that because of our projection. And then on the other hand, you can get under involvement, where somebody actually just repels us, like we don't like them, they're angry, it makes us uncomfortable, or what they've been through is like so horrifying, we are uncomfortable with that and we can't deal with that, so we don't want to see them. And so we may fail to provide support that we could actually provide and be useful to the person. So we have to be careful about both extremes. So we've talked about impact of trauma, how that can translate into risks for us in our work that we do with people. And so now we'll talk about some general principles about how we can support people who may have experienced trauma. And the same ideas apply to people who just experience a lot of stress in general. And then we'll talk about how to practically apply that to prevention measures and management of trauma. So there are 5 or 6, I put here 5 general principles for working with trauma that will help guide us through. So these are more of sort of a general awareness or an attitude or an approach rather than a specific set of techniques or skills that you can learn. So you have to take the principles and try to apply them to your particular area of work or your situation. And I think that's how it really needs to be, that, you know, there's not like a certain thing that you can say or a certain kind of relaxation technique that you can learn that that is just going to help you work with everybody. So hopefully by now, with all of the things we've covered, you are quite aware of trauma and how trauma can affect people. And just having that awareness, even if you don't purposefully or consciously do anything differently, will probably have a positive effect on your work. Because if you understand why people behave the way they behave and where something may be coming from, you're probably less likely to take it personally. And you're less likely to have a negative judgment of the client. So rather than seeing them as a bad person, they're somebody who's been through something very difficult and they're just living out the natural consequences of that. So that will make the work more tolerable at the very least. Another important principle is when people have been traumatized, the trauma has taken away their sense of safety, choice, and control over their lives. So as a general principle, the antidote to that, or something that's going to be healing, is things that we can do that help restore the sense of safety and choice and control that the person has. So some examples that I put here are informed consent, so that they have the information that they need to make a choice, so that restores their power and sense of control. Making the environment physically welcome and accommodating, and being clear and consistent in terms of what people can expect from us. So being clear about the boundaries, being clear about what we can and cannot do for them, clear about our role, and being consistent in that, consistent in how we schedule them, what we tell them, so that also enhances the sense of safety. And talking about empowerment is just a different way of phrasing the previous slide, really. If we restore choice and control to people, that is going to help empower them. So we can look at ways of trying to equalize the power imbalances that may exist, recognizing we're probably not going to be able to remove them completely, nor should we in some cases, like if we have power over people because we know things that they don't know, or we have special expertise that they don't have. That power imbalance is kind of natural or kind of necessary for us to be able to help them. But we can empower them by giving them information and helping them to help themselves, rather than doing things for them. Also, just listening to feedback from people and making use of that feedback is also empowering for people. So again, these ideas all interlap or overlap and interconnect, but if we work to empower people, it helps if we recognize their strengths and not just their deficits or their weaknesses, because recognizing their strength provides hope, and it gives people a starting off point. So they can see that they have something that they can build on to further empower themselves and be more and more able to fully engage their capacities, their abilities, and participate in society. We talked about the negative effects of trauma on staff, vicarious trauma and burnout. So it's very important for our organizations to be supporting our staff, because if you don't support people, they burn out and then they can't do their jobs effectively. So some of the ideas I think that help to do that are when people have a sense of meaning and purpose in what they do. Really, I think almost any kind of work, you can't just do it for the money, but you have to have some sense of purpose in what you do, that it's important to do and there's some reason for it. And that is what makes going through difficulties more tolerable and gives a sense of dignity to us. When I talk about internal locus of control, what I mean is we have to help people feel that they can influence the course of what happens to them. So when you give employees responsibilities, you also have to give them some power to exercise those responsibilities and some control, so that they can make decisions. Because when people feel like the situation is out of their hands, somebody else is calling the shots, they can't actually make things better for themselves. That tends to produce despair and burnout. So we can apply these general principles to our organizations and our individual practices to try to be aware of the effects of trauma, detect trauma early, and then try to minimize the potential harm that can happen. And again, here we're talking more about what's your general approach, the essence of how you work, rather than specific techniques that you just learn and implement. So the concept of universal precautions comes about because we do not necessarily know ahead of time who has experienced trauma and what kind of trauma they've experienced. even if we asked everybody, and it's probably not really appropriate to actually do that, they may not want to tell us. And even if they wanted to tell us, they might not actually be able to really articulate what's happened to them and how it's affected them. So if we can't know ahead of time who we need to be careful of, then we need to be careful with everybody. And that is what we mean by universal precautions. So if we plan our organizations and our work around the idea that people will struggle, that they will have difficulties, there will be problems, instead of planning around the ideal scenario, like clients who are organized and show up on time and know exactly what they need and are always present to us, then we're going to make sure we have enough reserve capacity built into our organizations to absorb the stress that's inevitably going to come up. The other thing we can do is just if we understand and we're prepared to do our core job, like we really deeply understand what we're doing, why we're doing it, and what our options are, then that also frees up extra capacity to deal with difficult circumstances or stress when it arises, because you're not spending your mental energy deciding what you should do in terms of your core job. That's hopefully overlearned, so you can devote your mental energy to, okay, how do I respond to this person who's going through something right now. So part of the universal precautions is creating an environment of safety, so we can, say, use principles like informed consent, asking permission, working in a collaborative way, making choices explicit. We can do that for everybody. So we don't have to try to select out who has trauma and who hasn't. And the good thing about this is, like, if we do those things, it makes everybody's experience better, because, like, who doesn't want to have choices, or who doesn't want to be consulted about what they think, or be more empowered. So following universal precautions, we can also just make our lives easier and less stressful for ourselves and for the people we work with. The other principle of prevention is self-awareness. So we've looked at the different kind of boundary issues that we can get into unknowingly. So the antidote to that is to be aware of what we're doing and why we're doing it, being more aware of our feelings and how our feelings affect how we behave. So that is actually like a whole different topic of inquiry by itself. So we could have a whole presentation about that. But in general, some ways of doing that is to have consultation with other people, whether that's supervisors or our peers. So we just run by unusual or challenging scenarios with them, and they may point out things to us that we weren't aware of. And then doing some kind of self-reflective practice, like having your own therapy, or practicing meditation or journaling can also be other ways of doing this. In terms of how to recognize the people that we might have to be a little bit extra careful of, like, we'll be careful with everybody, but if we see signs that maybe somebody is more likely to have trauma or distress, we can pay a little bit more attention to them. It's basically just looking for the effects of trauma that we've already talked about. And I think in particular, I would emphasize the interpersonal factors. So if you see somebody who just seems irritable or very demanding or very controlling or very fearful or avoidant, and they push our buttons or make us feel defensive, like that's somebody who may have experienced some kind of trauma in their life, and we might have to be a little bit more careful about that. So there may come a time when we need to ask people about their trauma. There's a lot we can do already without asking at all, just by taking universal precautions. But if we do have to ask, we need to know how do we do that. So the most important question I think we need to ask is, why do we have to ask about trauma? So that information has a cost to getting it. So if you ask somebody about their trauma, you run the risk that just telling you about it might be upsetting to them. It might burn up some of the relationship capital that you have with that person, because you're asking them to do something that's difficult. So if you don't know them that well, or you don't have that much of a rapport with them, this might be damaging to that. And it also just takes time to ask and to deal with the aftermath. So the most important question when we want to know about trauma is, why do we need to know? Like, what are we going to do with that information? Do we need it to make a treatment plan? Do we need it to make a diagnosis? Or do we just want to know because we're curious, in which case maybe we actually don't need to ask, or we shouldn't ask. So if we establish that we do need to know a specific piece of information about the trauma, we should be specific about what information we need to know exactly, not just, tell me about it from the very beginning and tell me exactly what happened, because that's like way too much information, more than we might want to deal with or need to know. We should also be selective about the time and the context, both the place and the relationship context. So do I have enough rapport with this person? Do they trust me enough? Is this a private enough place that if somebody breaks down in tears, they're not also going to be embarrassed or humiliated? And do we have time to address issues that might come up? So if it results in a very long disclosure or a lot of tears, and you need to process that, do you have enough time, or are you going to send them out of your office still shaking from the encounter, in which case they're probably going to have a bad impression of your service? Again, we want to be specific about what we need to know. We want to tell people why we're asking, what the context is, because that also gives them more choice. It's more collaborative. And we ask for permission, and we give them the choice, like, you can choose not to answer this question, and that's okay. And if you don't answer this question, this is what we'll do. Like, we'll just do our best without that information, or this is the approach that we'll take. So they can know about what their options are, and they can make an informed choice. So when we ask about trauma, we have to deal with the disclosure. And so here are some potential pitfalls or cautions. So we want to avoid extremes of minimizing the experience and invalidating it, and again, overemphasizing the negative and making assumptions about how it's going to affect their life, or what it meant to them. So in the middle is professional validation, like you acknowledge what they experienced, and that must have been horrible or very difficult, but you're not superimposing your opinion about how that would affect you, or how you think it affected them. And I just put a little caution here about what I've termed the bandage ripper. Like, some people are, for whatever reason, it may be that they're socially conditioned to think that, when you go to see the doctor, if you've had trauma, you just spill your guts and tell them everything that happened, and then you're going to feel better because it's a cathartic experience. That's actually not necessarily the case. Like, people don't always feel better talking about their trauma. So if you encounter somebody who just kind of launches into like telling you the whole story of everything that happened and just unloading everything, and you actually don't need to know that, it's quite appropriate just to gently interrupt them and say, are you sure you're comfortable talking to me about this? Like, it's very personal, it makes you very vulnerable. We've really only just met, so it's totally okay just to maybe wait until you know me a little bit better, and you might actually feel more comfortable telling me the things that you're telling me now. So something like that. You're not sending the message that you can't handle it, or you don't want to know. because what they've experienced is too horrible, but you're coming more from a position of care that, this disclosure might have effects on you that you may not be aware of. So, can I give you some information about that? Moving on to management, and hopefully we'll wrap up with some time for questions, I think 15 minutes or so. What are we managing? So we're managing the disclosures that we might get about trauma, and we also need to know how to manage emotions that might come up because somebody's been triggered inadvertently. So we'll talk again, as I promised, about what's the difference between trauma-informed and trauma-specific care, how to share information about trauma. So if somebody's disclosed to us that they have a history of trauma and we want to offer them something that we think might be helpful, how do we do that? And then how to manage trauma reactions. So the difference between trauma-informed and trauma-specific care is the trauma-specific service is like a specialized mental health service that aims at treating trauma-related disorders, whereas trauma-informed care could be provided in any setting with any kind of service. It just means you're aware of the potential effects of trauma and how it can affect the work that you do, and you're prepared to address those issues by providing information or directing people to more specialized services that can help them. So you do not need to be able to treat PTSD in order to be helpful. I think even if you just do your job providing the service that you're trained to provide in a trauma-informed way, and you empower people in whatever capacity you can empower them, that's already therapeutic and healing. So say somebody has disclosed to you that they have a history of trauma. You may want to share some information with them. So if you have the background or the experience or expertise, you may share some information that you know about trauma and how it can affect people. Because for somebody who has never considered the idea that they've been traumatized or that their present experiences actually relate back to past trauma, this can be quite helpful to normalize what they're going through and help them understand why they feel the way they feel. And you may provide them some specific information about dealing with a particular problem that they have or a resource that they need, or direct them to more specialized care. So one of the most important ideas about sharing information is that people may not actually want to know everything that we think they should know. So we deal with that by using an elicit, provided, elicit model. And that actually comes from the addictions field. So say, for example, somebody who comes and tells you that they smoke cigarettes. As a doctor, you may know about the negative effects of smoking. You might know about medication that's helpful for quitting smoking. You might know about a clinic that can help them with that. But if they're actually not prepared to receive that information and they don't want to quit smoking, then you just unloading them on that or unloading that on them may be actually totally useless or unhelpful at this point in time, or it might irritate them. So to avoid those kinds of problems, oh, sorry, I just got a comment, cannot hear or see the presenter, so I don't know if anybody else is having that issue. Maybe it's like a technical problem, but hear or see the presenter. So I'll just make note of that, and we'll kind of look at things on the technical side, and I'll keep going. Hopefully the others are still able to hear. But the elicit model, we start by identifying what the person already knows, so we're not telling them things they've already heard. we identify what, if anything, they want to know, and then we ask their permission to share that information. So, would it be okay if I give you some information about how trauma can affect people? And if they don't want to know, then we just leave it. And if they do want to know, then we provide whatever factual information um, they agreed to receive. And then the other elicit is checking in with them about what they understand, about what we've said, any questions they have, and just how are they feeling about what um, they've just been told, so that we have a chance to process a bit further with them if something like didn't resonate or they have further questions. Okay, so just gonna try to advance the slide. Okay, we're just in the chat box, so okay, here we go. So there's a short section on managing trauma reactions. I've kept it short because I think the emphasis should not be on managing trauma reactions. Hopefully we can actually avoid them by using universal precautions. And it's actually not really that common, I think, where you have to do this. Like I only have had to do it once in a while for people who come into my office like really highly stressed. So it's kind of looks like a fancy technical skill, or it's kind of like a cool technique that you can learn, but probably, hopefully, you won't have to use it that much. So first of all, how do you recognize that somebody may be having a traumatic reaction? So what that means is they are probably either experiencing a flashback or an intrusion, like re-experiencing a memory of trauma, and so they're being flooded by emotion and their body is going into fight or flight mode, or they may be dissociating. So the experience is so overwhelming that they're just checked out. Like the mind has just gone blank, they're disconnected from the present moment, and what they're experiencing like doesn't feel real, or they don't feel like they're themselves, and so they can't participate in what's going on. So if you see either of these kinds of situations, like where the person seems very over-aroused, tense, rapid, shallow breathing, sweating, shaking, that might be a sign of a flashback. And if they are not responding to you, they look dazed, they might be dissociating. And people can sometimes tell you this, like, oh, I don't feel like myself, something feels weird. So you can also just ask them, and sometimes they can tell you that. So general principles about how we want to deal with a situation like this is when somebody is experiencing this kind of reaction, it means their attention has been redeployed somewhere else that's not the here and now. So they're lost in a memory, or their attention is just on nothing, and they're dissociated. So we want to help them bring their attention back to the here and now, so that they can feel reconnected with their body and this present moment, and they can feel more in control of what's happening to them. The other principle is you want to try to help them do something that's going to physically calm them, like slow down their breathing, slow down their heart rate, decrease the adrenaline response. So I'll talk about two techniques that you can use to do that. One important thing that is not always obvious is that when you're doing this, you also try to ensure that you're grounded yourself, so that you're connected to the present moment and you're feeling calm, so that you can guide them. And also, with this kind of thing, you keep your eyes open for somebody who has experienced trauma, you keep your eyes open so you're connected to them and you can see how they're responding to what they're saying, and they keep their eyes open so they can connect with you and what's happening in the room. Because you don't want them to close their eyes and get lost in their traumatic memory or in their dissociation. So sometimes you use these kinds of relaxation techniques with somebody who's not experiencing a traumatic reaction. You get them to close their eyes so it's more relaxing, but this is not that kind of situation. So one of the classics that I find is quite helpful is box breathing. So it looks like a box, like breathe in for 2 counts, hold for 2 counts, breathe out for 2 counts, and then hold out for 2 counts before breathing in again. There's different variations on that, like you can breathe in for 3 or 4, just depending on the person's state. Like if they are really, really anxious, they're probably going to be breathing faster, so you have to kind of match them where they are and then slow down from there. Another technique that you can use along with box breathing is called scaling. So it gets the person, you just ask them, like, just on a scale of 0 to 10, how distressed are you feeling now? Do the technique, check in again, how distressed are you feeling now? And you should see the number going down. So what that does is it helps you to know when to stop. So when they're saying like less than a 5, that means you can stop doing the box breathing. And it also engages their mind and their attention. So it gets them to reflect on their experience and think about, okay, this distress that I'm feeling now, how distressed am I? And going through that process and like re-engaging those higher cognitive functions can also help to ground them and bring them out of that fight or flight response. While they're doing the breathing, which in itself is relaxing because if you slow down the breath, you slow down the body. You can also ask them to pay attention to their sensations. So the sensation of air moving through their nostrils, moving into their body and moving out of their body. Because connecting the person's attention to their here and now sensory experience is another way of bringing them into the present moment. Playing off this idea is called the 5-4-3-2-1 sensory technique. So if you look up the name of that technique in Google, there will be a few descriptions or scripts that come up. And there's different variations on this as well. For example, there's a different variation that gets people to pay attention to 5 things that they hear, 5 things they see, 4 things they hear, 3 things they feel, 2 things they smell, 1 thing they taste. That's a different variation. Here, you get them to go through 5 things they see, 5 things they hear, 5 things they feel, and then repeat with 4 and 3 and 2 and 1. But the basic idea is the same, like to get them to shift their attention to whatever internal experience they're having to their here and now sensory experience. So that can get them out of focusing on whatever unhelpful thing they're focusing on and just get them to focus on something that's more benign in the here and now. So those are the techniques. That is pretty much what I wanted to cover today. How to assist a chronic bandage ripper, not just first visit, but at every visit. Okay. All right. So let me just make a note of that, and then I'll just wrap up here, and then we'll go on to questions. So this is just a list of some resources that I think are helpful. Not all of them are actually specifically about trauma, but I think they do relate to trauma. I think people often just like to have books or something they can read more about. So a lot of this talk is based on the BC Trauma-Informed Care Guidelines from 2013. So those are freely available online. You can just look that up on Google and get it. The Jim Collins books I like, they just talk about building resilient organizations, not anything about trauma, but I think if you follow those principles, you'll have an organization that's better equipped to deal with trauma. Richard Swenson's book is about burnout and personal resilience. If you want to know more about self-management, that's a good resource there. And the Judith Herman book is really like the classic about trauma. The title's pretty self-explanatory. So now it's time for questions and discussion. So I'll just leave up the resource slide in case you want to copy anything down. So I'll just move into addressing this question about the person who, tries to share too much at every visit. So I think without knowing like all of the details about the situation, one question that comes to mind is, so you're attempting to make the sharing more appropriate or limited in some way. It's important to know why we're doing that. So there are a number of like very good legitimate reasons to do that. So for example, the person may be sharing so much that it's taking up all the time and you're not able to actually do your job or help them with the issue that they actually came to you for in the first place. Or what they're sharing just might be totally overwhelming and it's actually not helping them because they're decompensating emotionally from doing that. So I think those might be some of the good reasons to do that. With this kind of situation, you kind of have to be careful that you don't want to be coming from a place of like, this is overwhelming and I don't like hearing about it, so I'm trying to shut the person down, because if they feel like that, that may be an invalidating experience for them. So, so the approach that I find helpful is just to be transparent and direct with them about what's happening and why we need to redirect things. So, you can just point out, like, it seems to me that we've been going off track quite often, and we're actually going off track now. So I'm wondering, like, did you notice that? And hopefully they did. So that's a starting off point to have a conversation. So you could, ask some permission, like, is it okay to address this now? Because it seems to me like this is something that might actually interfere with my ability to help you, because you came to see me about whatever, like housing, or about your welfare application, or about say like your treatment for whatever ADHD or depression. So if we spend all of our time talking about what happened in the past, we will actually not be able to address the need that you came here for. So I'm wondering if it's okay when you start going off track like this, if I just remind you about what we came here for. And it's not to say that what you've been sharing is not serious or important, but just to recognize we have limited time here, so I want to be able to use it in the most effective way. And then the person may need frequent reminders about that, but you might just have to keep at it. And you can sometimes maybe like develop a code or a signal with them, like when I put up my hand like this, that's a sign that we could be going off track. So is that something that we can use? Because if they spend all of their time just spilling their guts, it's actually not necessarily going to be helpful, and that's important to be clear about ourselves, so we don't feel bad about redirecting them. the other thing I'd say is like even when we're there to help them with their PTSD or their trauma, um, if they don't talk about the trauma in an organized or controlled way where they feel like they have control over the process and there's a certain pace that helps them to process things, then they just become overwhelmed with what they're sharing, and it's not even useful for processing purposes because they just talk about it, they get flooded by it, they don't end up processing or understanding anything differently, and they're the same or they feel worse than they were when they came in. So if you feel comfortable, like you can also explain that, maybe not in so many words, but just that this kind of sharing or this experience under these particular circumstances might not actually be helping you, even though you feel like you need to do it. So we have a few more minutes. If there's any questions, just type them in the chat box, and I will try to address them. Also, just Maria, the previous talk about understanding trauma, like, is that available too for them? Okay. Okay, yeah, so the understanding trauma presentation is also archived on the website. So that talk also has information, like if you just want to know more in depth about trauma and PTSD and what treatment is available. For example, like if you may be in a position where you are directing people towards treatment, it might help you to know what some of the treatment options are, like more of the medical perspective. So you might find that talk to be helpful too. Okay, yeah, I don't see any more questions, and yeah, I think people have had the option of typing them in all throughout the talk. So if we haven't seen them by now, hopefully they've all come out. So I think we can wrap up here then. So thanks for your attention to this very important topic, and I hope you can take away some points to make your organization more resilient, provide better service to people, and also actually have a better experience at work, like just be less stressed and feel more prepared. All right, so I think that's it. Thank you again.